what's up everyone? Welcome back to the Endo channel. To any new souls out there watching, my name is Brittany Denson. Thank you so much for tuning in. I'm so happy you're here. Please consider subscribing to help support my channel. It's free. It's the red subscribe button down below in red. Yeah, hit subscribe. Thanks. We are kicking this new season off here at the Endo channel with another Endometriosis Live Endometriosis Expert Q&A that I hosted back in October. Endless love and gratitude to the genius creator behind Endometriosis Live, Joy Roberts, for continuing to trust me with hosting these community-shaking events. I sit down with 5 experts as they answer questions directly from the community, as well as hitting hot endo community topics. You don't want to miss it. I get it, not everyone has access to endo experts for their case. Never allow that to hinder your growth. You are your own best advocate. You deserve proper disease education and treatment, period. Before we dive right into the Q&A, upcoming on the Endo channel, I will be catching all of you up on my life before and after my back-to-back surgeries, 4th and 5th, with Endometriosis Expert, Dr. DeLumba. If you haven't traveled with me to Denton, Texas already for my sit-down consultation with Endo Expert Dr. DeLumba, check it out now. The link is in the description box below. You don't want to miss his passion for educating others on this wildly misunderstood disease. If you aren't already following me on Facebook and Instagram, my links are in the description box below. Come and find me and say hey when you do. And if you enjoyed this video, please help support my channel by giving this video a thumbs up. And don't forget to subscribe so you never miss a bit with Britt. We'll see you next time.
Welcome to Endometriosis Live, guest endometriosis expert Q&A. This program is not a treatment or diagnosis of said conditions or said questions and is for educational purposes only. Discussion does not supplement a patient-provider relationship. By participating in this discussion, you acknowledge and agree to these terms. You are welcome to contact said experts to begin individual case evaluation. Again, you should understand each case varies and requires individual attention and review. Thank you, and welcome to the discussion.
Thank you for joining us for another Endometriosis Live Endometriosis Expert Q&A. I am here with 5 experts ready to join the endo community hot topics. Now, before we dive in and meet each one individually, I would like to say my name is Brittany Denson. I will be your host today, and we are going to get started with first a group of theme discussions and then answering your questions here live. All right, let's meet our guest experts. Nicholas Fogelson, MD. Now, he is the founder of Northwest Endometriosis and Pelvic Surgery in Portland, Oregon, with particular expertise in the management of endometriosis. Dr. Frank Tu, Chicago, Illinois gynecologist treating endometriosis, fibroids, and pelvic pain, combining advanced surgery with multidisciplinary medical therapy. Dr. Ted Lee, Director of Minimally Invasive Gynecologic Surgery of University of Pittsburgh Medical Center at Maggie Women's Hospital. Now, he is a 5-time Golden Laparoscope Award winner for the best surgical video by the AAGL. Dr. Iris Karen Orbach, Director of the Advanced Gynecologic Laparoscopy in Los Angeles and New York City. Specializes in endometriosis and pelvic pain. Dr. Jeff Arrington. Unfortunately, he is not going to be able to join us today unless he hops on late. He is actually in the middle of a really hard case, which I'm curious to hear more on those details. But yes, he is knee-high in that. So we will hopefully see him later. If not, we got this. All right, guys. So let's jump right in and kick this Q&A off with discussion themes. The very first one that we're going to dive into is centralized pain. Now, let's see. We're going to start with Dr. Fogelson with centralized pain. So Dr. Fogelson, how are you today?
I'm good, Brittany. Thank you so much, and thanks to Joy and to the community for inviting me to do this. I enjoyed doing it last time, and thanks for inviting me back.
Of course, thank you to everyone that joined us today. I know you guys are busy, and I know that Joy spends a lot of time and effort to collide with all of these experts to get them to you to have at your disposal. So thank you all for your time. Fogelson, let's get it.
So centralized pain is the concept that there is pain that is coming from a very specific thing in the pelvis. And we often say that, endometriosis is painful because every single month, endometriosis is getting inflamed and it's causing an immune reaction, and you're getting localized inflammation that's causing pain. And if that inflammation is close enough to a nerve, then it's going to send a signal to the brain that says, ouch, something is hurting, and that's what we perceive as pain. Sometimes endometriosis can even hurt when you're not at a particular time in the month. If the disease is close enough to a nerve that it's compressing a nerve, it may hurt all the time. Centralized pain, rather than being a specific thing that is injuring telling the brain there's pain, it's actually sort of a dysfunction in the nervous system itself, where despite the fact that whatever is causing pain is gone, the brain is still perceiving pain. And it's basically that the nerves are still firing and saying this thing hurts even though it doesn't hurt anymore. So that's a bit of a problem in people that have really extensive endometriosis who have had very long-term pain, where they said, I've been in pain for 20 years. You can go back and do a beautiful surgery, and usually a component of their pain will be gone, but there may still be almost an echo of that pain that can go on for a long time. Just like if someone has a traumatic amputation of their leg, they may feel their leg later. Sometimes people perceive pain later, even though you've removed the source of the pain, arguably. And for that reason, I think that endometriosis surgery needs to be done multidisciplinarily with a lot of other things. We can't look at the other things that we might do as being sort of what we do when surgery doesn't work. We need to look at it as something that we should do with surgery so that surgery works better. And those kinds of things are neuromodulatory drugs like gabapentin or Lyrica. These are things that work on centralized pain. Acupuncture seems to work for centralized pain. I don't understand necessarily how, but the data seems to show that it does. There's also interesting kind of neurologic surgery things that we may be able to do with centralized pain in the future, like neurostimulation of pain as well. And that's where, kind of where that's all. And it's a difficult thing for patients who have surgery that sometimes still have pain, because that is an element. Sometimes people are saying, well, there was some endometriosis missed, that's why they still have pain. And that may be the case. But also sometimes it's the case that we really have removed all the endometriosis, but there still is this sort of neurologic pain. But I would love to hear what my colleagues think as well.
Dr. Tu?
That's a great intro to the concept by my colleague. I guess probably the key areas to think about when you're talking about centralized pain disorders in general, if you step away from just women's health conditions but look at the broad issue of chronic pain in the United States, probably affects upwards of about a sixth of individuals, both the young and the old, reproductive age women certainly as well. And at the heart of the reason why we don't always think a single treatment will work for pain disorders is the fact that the human sensory systems have evolved to help us to determine if there's a threat that exists that would possibly affect our overall health. And in many of the pain states, when you have a person that actually presents with the actual symptoms of pain, it could be that the central nervous system has taken the sum total of a person's exposures to threats, exposures to injury, and is making the determination there is something that the person needs to do to avoid future harm or threat. Whether or not that's always a correct interpretation by our nervous system continues to be a really big area of research and inquiry. When Nick mentioned the fact that nerve drugs like Lyrica, or we would call it pregabalin in its generic form, or some of the other drugs like Neurontin are employed in this setting, it's targeting the idea that perhaps some of the nerve circuits have become really efficient in communicating information from the periphery, in the case of a woman, her peritoneal cavity, up to the parts of the brain that are going to be deciding whether or not something needs to be acted on. And that decision is what results in actually someone feeling unpleasantness or actual pain. But we don't always know when we talk to our patients whether or not there is a much more complicated sort of convergence of the issues, the threats, the actual injuries they've actually experienced, including inflammation from the monthly cycle, that might be resulting in that determination that someone should be reacting to it. And so it's, again, to echo what Nick's saying, it's essential that you do take a multidisciplinary approach to endo, because for any given person who comes in, we really rarely would have the chance to understand the entire lifespan that they've kind of gone through and accumulated. That's where I think there'll be some discussion later on about the critical importance of doing a proper history and physical exam before you decide how to treat an individual that's in front of you in the office.
Very good. Okay. Very interesting stuff, guys. Okay, so let's move on to the next theme, the importance of proper examination and documentation, both for patients and providers. So we're going to start with Dr. Lee on this.
Well, I think it's what Frank was saying earlier, is that it's extremely important to have a proper, actually we go back to the basic, to have a good history and good physical exams. And frequently that, a lot of times that we don't always, a lot of people don't really pay attention to that. They jump right to a lot of imaging modalities and so on. But I think it's very, very important to take a really good history. And the exam is also very, very important as well. Unfortunately, most of the OB/GYN residency program do not have mentors to teach them how to do a proper history and proper exam. Mm-hmm. Take, for example, rectal vaginal exam. If you ask a group of OB/GYNs out there in the audience, ask them, how do you do a rectal vaginal exam? Most of them would not know what to do, won't have a proper answer for you. And it's very, very important. And I think Frank is obviously very, very well versed in pelvic pain, and all of us who are endometriosis specialists have to be very well versed in be able to triage different type of source of pelvic pain. But we do a very compartmentalized exams, and the reason for doing a proper exam is so that we can reproduce and localize the source of the pain. The more precisely I can do that, the more likely I can help the patients. So frequently in patients with centralized pain, as mentioned earlier, the pain is not as reproducible as somebody who has much more sort of, who has like a endometriosis at the right trosacral ligaments, for example. The patient have been telling me that I have monthly right-sided pain with my cycle, and I touch the right trosacral ligament that reproduce the pain. That gives me a lot of confidence that surgical intervention is likely to help. So it's very, very important to that, is to be able to correlate the history and the physical exam together. So that's my take on in terms of the physical exams. Obviously, I don't want to go into the minutiae of the different things that I actually do. And the other thing is that my exam also allow me to direct how I'm going to use that information to help me to decide if I need to do any further imaging, for example. If I feel nodularities on my rectal vaginal exam, chances are I'm going to perform an MRI, typically with the rectal vaginal contrast, be able to sort of get a full extent of the disease. And so that is, so the exam and the history and exam will help me to decide what else to order, because you certainly don't want to order MRI on every patient because that becomes very costly. I'll let Frank to speak a little bit more about that as well.
Okay. Now, I was going to be going to Dr. Arrington more on this topic. Is there anyone else that would like to add on before I move on to the next theme? Or were you done? I'm sorry. Did you want to add anything else?
I have something brief to say if no one else would.
Yeah, go for it.
One of the things that a lot of people know is that there's a limited number of people in the country that have really, top good skills with endometriosis. And so a lot of times patients travel. And I think it's a problem because I think that I don't entirely know what I want to do for a patient until I've really examined them and talked to them. And yet we're kind of in a situation where we're reviewing a chart on a patient that's 2 states away, and that we're actually going to get an operating room time and try to have a surgical plan on a patient that we've never met. And it's a problem. I mean, it's going to be a lot better if there's people in every community that are really good at doing endometriosis surgery, because there could theoretically be a case where you have an idea of what you're going to do and you set it up, and then you show up and you don't even think the patient needs surgery, and the patient now expects surgery, and yet you've kind of made a plan based on really just indirect information. And that's why the exam is so important. And the only solution is ultimately train our fellows, train more doctors, so that every community has, at least a few good people that can work with the patients.
I think it's just, it's one of the problem with, people traveling for surgery is that I think sometimes you have to sort of make into a 2-visit process, that you be able to assess them with physical exam and then get to know the patient better. I know people do like interviews over the Skype and so on to figure it out, but sometimes, exam is so important too. And unfortunately, also the op report that we get from the patient's previous surgeries are frequently very, very poorly documented. It's usually don't actually give you the information, and sometimes give you false information. There are times when
as good as they know.
There's endometriosis, there's no endometriosis, and when there's, it can be vice versa as well. And so what I advocate is actually have, for my patient, I actually provide the pictures of before and after to document what I see and what I remove. So people have a very good understanding of what was actually done. And I think in the future, I hope that become part of your documentation in terms of ability to prove what you have done in terms of coding. So I'm actually advocating to have the photo documentation as part of a coding to get reimbursement for the surgery that you perform. Because a lot of times people are not very, to be honest, not very truthful in their op report. They say a lot of things that may or may not be there. And I'm sure all of you have seen op report that has totally different than what you see when you get in there.
Can I make a comment just about, can you hear me?
Yes.
Okay. I want to just make a comment about how differently I treat endo over the last 5 or 6 years as compared to when I finished my fellowship. When I meet a patient, I've obviously, we try and get the patients to submit all of their medical records, their operative reports. But typically when I meet the patient for the first time, I like to ask them, what brings you here today? Because when I hear the words that my patients are describing as their pain, that really helps me try and figure out all the other pain generators that are typically causing the patient's pain. Because typically there's a 5-year, 10-year, 12-year delay in diagnosis, and most of these patients have pelvic floor dysfunction. Many of these patients have centralized pain. Many of these patients have a lot of anxiety and depression, plus perhaps hernias, a lot of other generators of pain. And typically, when I meet a patient, it's rare that I'm booking them for surgery right away. For instance, if they have, they've been straining and they have had constipation for the last 5 years and they sit on the toilet for a half an hour just to have a bowel movement, probably the tight pelvic floor muscles are a huge component of their pain. I prefer the first thing, I try and do non-surgical things, ultimately explaining to the patient that excision of endo is what you need for the endo, which set off all of these processes. But excision of endo isn't going to make the tight muscles better. First stop I typically send patients on is to a pelvic floor physical therapist. And I tell them, I want you to try and do at least 6 or 8 pelvic floor PT sessions prior to going into surgery. If a patient has a lot of anxiety or depression, I want them to be managed better. Typically, I'll have them work with a pain psychologist, and it's amazing how much better those patients will do if they have centralized pain. I typically want them to be on, whether it's Lyrica or low-dose naltrexone, or start meditating or doing yoga or doing mindfulness. And I usually will bring them back at 6-week intervals. And maybe they have painful bladder syndrome, maybe they have other reasons for pain. And every 6 weeks, we keep just tackling and tackling. And what initially started out as this pain that isn't localized, like what Ted was saying with the right uterus sacral ligament. This isn't the patients who say, I ask, where's your pain? And they say it's in my belly or in my pelvis or it's in my abdomen, and they can't localize it. And I know that there's multiple reasons for pain. Over time, if they've done a bunch of pelvic floor PT sessions, if I think they have painful bladder syndrome and I eliminate the acids and the potassiums and really counsel them about that. If I have them work with a pain psychologist, I find that the patients will be able to attribute, oh, wow, I can sit better now that I've been working with a pelvic floor physical therapist, or I'm a lot calmer and less reactive if they're working with, someone for their anxiety. And I find then I decide to operate once we've really knocked out all of those other reasons for pain. And I find those patients do so much better. I'll send my patients home with a script for a narcotic. I would say most of my patients, there are outliers, it's a bell curve. Many of my patients will take no narcotics post-surgery. And if they do, they'll take one or two, because some patients come to me and want surgery tomorrow. And I tell them I would be the worst doctor ever if I operated on you tomorrow, because their muscles are so tight, they're so centralized, they're so anxious. Maybe they have obsessive compulsive disorder, whatever reason. I would be anxious and depressed if I went for 10 years to multiple physicians who couldn't make me better. And I find if I take a patient to surgery to the day after I met them, they're going to have so much pain from all of these other coexisting conditions. Then they're going to need narcotics. Then they're going to be straining more. It's going to flare their pelvic floor tight muscles, which is going to flare their central nervous system, which is going to upregulate the central sensitization. It's going to make them more anxious. And then it's just a downward spiral. So I always tell my patients, I'm not trying to be mean, but I really try and knock out all those non-surgical etiologies and treatments. And then we do a really good excision, and those patients do so much better than when.
You're inspiring me, or ours.
What'd you say?
You're inspiring me.
And listen, it'd be so nice to just meet a patient and fill up your OR schedule, a week later. But typically my patients, I'm operating on 6 weeks later, 12 weeks later. I have some patients who've been in pain for 20 years, and it's taking me 9 months to downregulate them. And I cannot believe how well they do post-surgery. And that's typically what I do with my patients. And that's what I'm writing a book on right now, a multidisciplinary approach, an East meets West approach to endometriosis and how a woman can regain her life. Because I think all those other things, the things that I never learned in fellowship, that I only learned through like International Pelvic Pain Society, working with urologists, working with PTs, working with psychiatrists, I think those are so important in addressing a woman's pain.
Absolutely. I agree. And I love your approach. I love exhausting all of those avenues.
Mm-hmm.
Okay, so we have two more themes. I'm going to skip to Dr. Lee on this one, and Dr. Tu can chime in right after that. But we're going to start with important roles of diagnostic testing. Now, seeking the full extent of the problem. I am really curious to hear more on this. Dr. Lee?
Well, let Frank start first, and then I'll stay after that.
I'm sorry?
I'll let Frank start first.
Okay.
To go to what Iris said, a lot of the themes that she brought up in talking about a comprehensive approach, almost like a prehab, if you will, in order to downregulate the individual. When we talk about diagnostic tests, the physical exam actually, as Ted already talked about, actually does constitute a diagnostic test. You can infer from whether you feel pain or feel nodules on exam, information about what you're going to do for treatment, no different than if you're looking at an MRI, you're looking at a blood test. And it is one of the most frustrating things about endo is that we don't have a stable biomarker for disease right now that could be drawn out of either tampon sample or, a blood draw or something in the urine or saliva. But there's a lot of companies working on that sounds encouraging, because for some patients, having the information could potentially help them make earlier decisions about either treatment or lifestyle changes that might allow them to get, like, for example, into something like mindfulness, meditation, dietary changes. But at the end of the day, if you're really talking about the basic role of like what constitutes appropriate and minimum diagnostic testing, your first thing is still the diagnosis is made, of course, surgically. But we like to tell patients that when they come in, we don't know if they have endometriosis, and they really shouldn't have to either. What we know is that generally, unless they're coming in with an infertility issue, or they have a mass that someone found because they were imaging their kidneys and found something sitting in the pelvis separately, they're probably coming in with discomfort. So we're really starting with the question of why do you have pelvic discomfort, not how do we know you have endometriosis. So diagnostic testing is to, first of all, just make sure that we identify, A, is it in some sort of a organ like the bladder, the bowels, or the uterus, or the ovary, or is it something more like in the skin or the somatic tissues? And once you've identified if you think it's more organ-based or if it's more in the tissues, then you can decide about the value of actually doing some sort of imaging. I'd say that once we are concerned that there might be organ involvement, that's when we might decide on certainly something to start simple like an ultrasound, which doesn't require any radiation. If that comes back with some information about, of course, the ovarian targets being more prominent. There's a mass that sometimes makes it very simple. But at the same time, as Ted alluded to, if you're getting a history that strongly points to some sort of issue with, like, say, bowel or bladder dysfunction, an MRI may be warranted, particularly if you can feel on the exam a suggestion that there's a mass buried deeper in the pelvis that actually might involve the colon. And at the same time, when you're doing your physical exam, you're not going to be able to get imaging right now that will tell you if the pelvic floor is a problem, but while you're doing that exam, you're getting a nice chance to look at the muscle anatomy and the patient's tissue response when you're actually actively palpating those tissues. And a lot of doctors that are well trained in doing bladder treatment, whether it's prolapse or whether it's incontinence, will already have a good angle on how to look at pelvic floor. But I think for a lot of the practitioners, like family practitioners and internal medicine doctors, they really, that's the one missing area, is to get a chance to look at pelvic floor and to look at the upper part of the rectovaginal septum. So those are the sort of ways that I think I'd use to decide how we get from the initial evaluation to who needs imaging. If it's something more extensive, I imagine, Ted, you could probably talk a little about whether you ever consider doing any sort of venograms. I very rarely think there's a role for that right now. And you know, some of the more interesting stuff that my PhD colleague has helped us do is try to start looking at dynamic MRI, where we'll actually try to look at blood flow and perfusion, but that's still probably about a good 5 to 10 years down the road before we can apply that to patients. We're doing it mainly on just research subjects. But yeah, that's I think the framework. Ted, what do you think based on that?
Yeah, I think it's, I think for me, the diagnostic imaging or the test I do is actually going to become part of my informed consent process, because especially patients with severe endometriosis, like involving bowel, bladder, ureter, and so on, it's sort of allow me to get a better informed consent process. So patients are fully invested in the treatment plan, because certainly nobody likes surprises. Like you don't want to go in a surgery and the patient is not even aware of the extent of the disease and potential for all the different type of visceral surgery. They don't. So it's better, for people who can do this type of surgery, it's better to know this upfront as much as possible and be able to inform the patient what are the procedures that are likely to help them, so they are fully aware of the risk and involved with the surgery that we plan to do for them. So that's how I use the MRI. I think we typically, for the MRI that we perform for endometriosis, that we use a rectal and vaginal gel, and now allowed to see the big nodule endometriosis in the uterosacral ligament, cul-de-sac, the rectum. And bladder endometriosis are so easily seen on MRI. And what I like about the MRI is that it gives you a lot of perspective regarding the relationship of disease with different organs, so that you can kind of have in your mind, sort of be able to plan the surgery in your mind, how things going to go. And with that, you can sort of talk to the patient as to how you envision the surgery is going to go and what is the likely scenario when we get in there and what we plan to do. And so be able to discuss different contingency plans. So if we see this, this is what we plan to do. If we see that, this is what we plan to do. So patients are aware of what's going to happen, because you don't really have the opportunity to work with the patient in the middle of the case to discuss with them the plan. So the better you know about the patients, the better it is for everybody involved. And that's how I see it. I mean, and also besides MRI, we frequently do endorectal ultrasound, especially with patients with like bleeding, rectal bleeding during their period, where you cannot really palpate the nodule because the nodule is further upstream, out of reach of your finger. Those type of patients also allow you to sort of be able to localize the lesion as well as the size and how far it's from the anal verge, because the location of the nodule of the rectum and the anal verge will determine how likely diverting ileostomy or colostomy needs to be done. So those are the type of things that I use those information to help to guide the patient as to what extent do they want to do the surgery. That's what my take is in terms of imaging. And for me, it's like I said, I don't do imaging on every patient. I only do it on patients who I know have very high likelihood of a deep invasive disease.
I think also, we often have to involve consulting surgeons. I think all of us have a lot of facility with bowel and urinary tract surgery and what we do, but at the same time, we'll involve colorectal surgeons or urologists in surgeries at times. And so knowing that one is going to need the resources of another surgeon is very important, because they're not just waiting around for you to call for them, that they're doing their own stuff. So you have to be able to predict that, or you may find that you get into a surgical situation that requires a consultant surgeon, either because you need them or because the hospital says that you need them. So that's where it really can come into play, particularly if this patient is not local to you, then it really helps to know.
Yeah, we have like monthly imaging conferences with our radiologists. So that really helps, because we actually show the actual surgery at the time of the conference, so the radiologist can actually learn from the process as well. So we find that the interaction between radiologists and the gynecologic surgeons to be very, very helpful. It's extremely educational for both parties.
Ted, what is your radiology batting average for adenomyosis on MRI? Have you guys ever looked at your pathology and MRI reads?
Yeah, in terms of, I think adenomyosis is usually diagnosed by, because sometimes when we were doing imaging for endometriosis, and so they may mention, oh yeah, by the way, this patient also has adenomyosis. I think they are fairly accurate, but they're not very, they have the sensitivity of adenomyosis, it's not very high, mm-hmm. But once they call that as adenomyosis, they're usually right. Mm-hmm. Okay, yeah, so they frequently, when they will not overcall adenomyosis, they undercall a lot.
Yeah.
Okay, so Dr. Orbach, can you hit on this popular topic in the community? I, for one, am very interested to hear your thoughts on it. Pain after excision surgery, what does it mean?
So, typically I get a lot of patients who have had pain after what they're calling excision. I think the question is lots of times gynecologists will say they did excision, but they didn't truly do excision. So they often will do an excisional biopsy and then ablate the rest. Mm-hmm. So let's take that separate as compared to like a good excision surgery. So if someone didn't truly have excision, I don't think that their endometriosis was addressed adequately. So their pain could be from the endo. But typically I do things a little differently. How I had said, I do a big workup beforehand, because very often if patients are coming with pain post-surgery, they could have pelvic floor dysfunction, they could have hernias, they could have painful bladder syndrome, they could have central sensitization. And I think it's important, and that's why I address all of those before I operate on patients. I can't tell you how many women who've had hysterectomies, which I think is so important to say. Hysterectomy is not the treatment for endometriosis, nor is castration the treatment for endometriosis, which parenthetically is what I was taught when I was a resident, if you can imagine. So I have had so many women come to me, young, just recently married, who want kids, who've had a hysterectomy, and they say, I'm still in pain, or I'm in worse pain than I was before. So typically that's because the endo was not A, diagnosed, visualized, and B, not excised properly, because it's so important to know that there's so many varied appearances of endometriosis, and everyone on this panel knows all the varying appearances. It can be yellow and blue and red, it can be clear, it can be fibrotic and white. But that's what I learned in my fellowship. I did not learn all of those appearances when I was a general OBGYN or when I did my 4 years of residency. So I think it's important, if you're being operated by a generalist and you're still in pain, that probably all the endo wasn't evaluated, it wasn't identified, and B, it probably was ablated rather than excised. And then importantly, you really need to look for all the coexisting reasons that I had specified earlier. I think that's the most important thing to do.
So I know it's challenging whenever you have a patient that comes to you and has had at least one surgery, if not multiple, by doctors. Let's say that these doctors were not specialists and they performed ablation. Does that hinder you in the way you're putting your name on that surgery now, on their case, if you will? So when you go in there and there's already been shoddy work, for lack of a better word, done, and you're going in to help this person, I know that's got to be difficult for you guys, but can you kind of how does that coincide together? Because I know that I personally am dealing with that. You go to a doctor that doesn't do it properly, and you go and seek expert help. At that point, are you?
I think
it's a really important question, but actually, Iris, you take this. You probably see a fair bit of this where you are on the West Coast.
Yeah, I think the most important thing is the first surgery done right. And we know, when we're talking about endometriomas, the Cochrane database really says that the first surgery for endometriomas is the most important surgery in terms of lack of reoccurrence. But, it's, I think everyone on this panel has operated on patients who've had 6, 8, 10, 12, 15 surgeries before us. And we do the best job that we can, but we can do a far better job if we're catching the patients on their first surgery.
Just from a point of view of technically, when you can really see how people operated before when you go in and operate, because sometimes you'll see an area of endometriosis that looks like it's been spot welded to the side of the pelvis. And clearly what they've done is they went in and burned it with a coagulator, or maybe they burned it with a laser, and they probably superficially destroyed some of the lesions, and the patient may have felt better for a few months or maybe even 6 months. But then when you go in there, this lesion that probably at one point was fairly superficial has now been kind of welded to the retroperitoneum underneath there. And you go back and you open up that space and you find out that lesion is much more deeply adherent. And one can imagine that it may not have been that deeply adherent the first time it was treated. You just see that over and over. But it's hard for people. People perceive that you should go see a specialist when you're not getting better from typical therapy. But unfortunately, our ability to do our best work is kind of hindered by someone else mucking around in there first. That's the reality.
I would say that the realities of how women's care is actually produced and performed in this country are very different than what our aspirational goals are. So I rarely try to use words in front of patients that are negative or pessimistic regarding prior treatment, and partly because a lot of my colleagues who are not gynecologists have indicated that the best outcomes in healthcare come from an optimistic, forward-thinking approach to healthcare. So even in the language of how we teach our young trainees about how they're performing the operating room, we don't try to use persistent, dwelling on how they did not behave well in the past, and whether it's the clinic, the operating room, but rather we talk about how they're going to be, visualizing a success in the future. So I think it's important to step here and say that while it is unfortunately the case that we'll get patients that I would say get suboptimal treatment, I don't mean suboptimal in the way that I say that someone is professionally negligible or they're incompetent. What I would say is that there are better results that we get in certain situations as we get more information, or we're in centers that have happened to see a lot of very, very complex and high volume cases where we have the benefit of researchers, multiple, clinicians that work on an actual true interdisciplinary team. And those of us, all of us are in big cities, are on this call right now, and we're all very lucky to have that. But we get referrals from the inside of the interior of the United States, which represents a huge amount of patients. And it's just not realistic that individuals sitting in a small town that has less than 100,000 individuals in the county are going to get the care they get in Portland or in Los Angeles. And that's a real problem that, maybe with telesurgery or teleconferencing we'll be able to overcome. What I will say is that it's really, I don't think ever something that we feel bad about if we've seen high volume surgeries, in our careers. When someone comes in who's had maybe a minimal attempt at ablation, it's perfectly okay for us to start with that as a starting point. Iris has pointed out very articulately that no matter what the person comes in with, if they haven't had enough endo treated, if they haven't had enough pelvic floor treatment, if they haven't had their social needs met or their anxiety, depression met, whatever it is, each one of those things may make them not capable of reaching the broader health goals they want. It's not just about one surgery. It's the total package. And the patient themselves sometimes can tell you where their focus needs to be on where they want things optimized. It's fortunate for us that we oftentimes can use surgery as an effective treatment for them, but it's just one of many, many tools that, I think all of us have on the call stated here. So no, I wouldn't say that we are limited in any way by what's done in the past. If anything, the fact that it takes as long as it takes, the 10 years that people quote in the literature for time to diagnosis of endo, really reflects the fact that pain is a multidimensional process. Someone may present with just painful periods at 15. It doesn't become full-blown pain until they're 25 or 27, when maybe their posture has caused things, their lack of sleep or stress or poor diet for a decade. So we just have to be positive about it and keep moving forward, I think.
I'm going to throw a curveball here regarding like pain after excision of endometriosis or any kind of treatment for endometriosis. I think a lot of times we automatically assume that the previous doctor did a poor job, but the other thing we have to consider is that endometriosis can be incidental. It just happened to be there and somebody made a diagnosis and may have nothing to do with patient's pain. That's why it's very important to take a very careful history and be able to match the patient's symptoms and then their exam. I have patients who actually, for example, have 2 prior C-sections, had a lot of pelvic pain, and somebody did diagnostic laparoscopy and said that you had endometriosis, and then the patient comes to see me and say, well, I need to have my endometriosis excised. When I examined her area of endometriosis wasn't even tender, and most of her pain is coming from the uterus. So a lot of times, the reason why treatment of endometriosis or excision of endometriosis does not help with the patient, it's not because it was poorly done, it was the cause of their pain, it's not from endometriosis. So a lot of times when we give the patient, when the patient who has been seeing doctors after doctors and they give them the diagnosis of endometriosis, a lot of times it's very hard for them to say, well, there could be something else. Because they sort of grab onto a diagnosis and it's hard for us to change their mind. So that's the one thing to consider is that sometimes endometriosis is incidental. It's not really it doesn't equal to the cause of the pain. It's a common cause of the pain, but doesn't mean that's the only cause of pain for patients.
We've all seen patients that have really terrible endometriosis that don't have pain. In fact, their only expression of endometriosis is that they can't get pregnant. And I've even seen people that have terrible endometriosis, no pain, and had 5 kids. The disease is not, I've said this over and over, and I said this last time we did this show, it's not just one disease. There's probably 20 diseases that we all call in the same basket of endometriosis. And some people have pain, some people can't get pregnant, some people have none of that. And that's why, if surgery is your only hammer, then everything is a nail, but we need to have more hammers and more ideas and multiple things that we can do. Absolutely.
I would like to take a moment to welcome Dr. Arrington. Thank you for joining us. This is Dr. Arrington, everyone. He is Atlanta, Georgia gynecologist specializing in minimally invasive robotic-assisted gynecologic surgery with expertise in endometriosis and pelvic pain. Arrington, would you like to join in on the excision, pain after excision surgery?
The only thing that popped to mind that I'd like to add is, unless we have operative reports to me are very poor to judge off of, unless we know the doc who did the prior surgery. Operative pictures are great. Unless we have good operative pictures showing all the different areas that coordinate with the patient's pain, as Ted had mentioned and Nick chimed in, occasionally we'll get patients who will have surgery after surgery after surgery, and every time they're told, well, it's your endometriosis, it always comes back, there's no cure for it. Eventually, we may get to the point in a particular patient where there can be a benefit of surgery, quote, with one of us is a high-volume endosurgeon. We know some of the atypical forms to look for. Some of us delve into nerve pathology a little bit. That there can be a benefit, even one of us going in and say we don't find any endometriosis. But then we need to be very clear with that patient to say, look, at this point we need to and we can take endometriosis off the table. And sometimes that will free that patient up to then be able to focus on some of the other different pain pathologies that we see with the nerves, with the pelvic floors and other nerve generators that we get so many of these patients that for years and years and years and years, it's been ingrained in them that all of their pain is endometriosis related. And if we can get to that point where, look, as far as we can tell, the endometriosis at this point is a non-issue, we need to change our thought process and start looking into some of those other pathologies that can be causing pain, and maybe get somewhere where we haven't been able to get for the last 10 or 15 years because we've always focused on endometriosis.
Very true. Doctors, anyone else want to add on to that before we move on to community questions that came in?
You know, one last comment I'll make is that the challenge of endometriosis is it really is sort of like, I mean, the analogy about sort of Goldilocks, where things are too cold or too hot. It is really a challenge of, like, it's almost like there's either too little attention to patients who probably almost certainly have endo, that have suffered for 10 years and are working productively and just sucking it up in ways that only women know how to do. And there's people that are getting told they have too much endometriosis, where in fact it's, again, like you heard Jeff talk, you heard Iris talk about, where they've got so many other things going on that are not endo. And I think that regardless of who the physician is taking care of the patient, I think they have to have a healthy respect for that you can go in either direction too much. We need to do more identification, especially probably in some of the smaller communities where there's just not as much access to surgeons. But probably in the bigger cities, ironically, there might be a rush to simply label too many people as having endo if you need to see a string of just general gynecologists who haven't had a chance to go to a meeting like the IPPS or AAGL global pain meeting. So that's probably on us to try to figure out how to do a better job of educating people that there needs to be this sort of sweet spot of endo treatment. But it's good to see that everyone on the call is kind of the like mind that we can do better.
Absolutely.
I think that there's a little bit of, you know, in the online communities, a little bit, there is sort of this promotion of the idea that if somebody didn't get better from surgery, it was the wrong surgeon and we need to find the right surgeon. And that there is a magic surgeon out there that's going to fix the problem. And the reality is that there's ineffective endometriosis surgery, and then there's good endometriosis surgery. But there's also all these other pain generators, and there's also people that have, you know, I disagree. I mean, they've had very good surgery, and we need to start working in the other ways that are going to help them. And also consider that if somebody has serious misery in their life from pain, and we've done surgery for them, and they can honestly say that they're 60 or 70% better than they were a year ago before surgery, then we have to say, well, that's a measure of success.
Yes.
If people have an expectation that I remember a time in my life when I had no pain, and until I get back to that, then I'm still miserable and I'm still a failure and my life is consumed. I'm powerless to get them back there. Like, the best surgery in the world will not get them back to the point where they never have any pain at all. I mean, very unlikely. Mm-hmm. And yet, if they can honestly say, wow, I don't have pain when I defecate anymore. I'm able to have sex. Yes, I still have pain when I have my menstrual cycle, but I'm able to take some Tylenol or ibuprofen. Where in the past I was on narcotics, and I still occasionally have flares where things are bad, but I used to have that 15 days a month, and now it's only a couple days every 3 months. That's success. And we have to call that success and stop calling that we didn't get there yet, because otherwise we'll just keep fighting forever. And so we have to be in partnership with our patients and understanding that that's success. That's not got there yet.
Can I make a comment also, is that I think rushing to surgery or multiple surgeries in a patient who does have central sensitization, you're upregulating their central nervous system even more, and very often causing more pain in those patients. So I think it's very important to, not to beat a dead horse, but to really identify, why does that patient have pain, and don't be in a rush to operate. Really question your doctor, do your research. And I just recently, I think it was Friday, saw a patient who had one surgery, then another one 3 months later, then another one, and then they wanted me to operate on them.
And I healed from the first one.
Yeah.
I said, as much as I would love to operate on you, we have to really optimize you first before we even consider taking you to surgery. And I think it's just very important for patients to understand that we can't rush into surgery unless there's a reason, ovarian torsion, or sometimes there's a reason that we have to get there quickly, but many times it's not.
I see how a lot of patients, being a patient myself, I can see where Dr. Fogelson was making his point in regards to changing the way, your mindset. It's about quality of life and not being pain-free. But then I can also see the other side of it as a patient when you're living that and you're having to get up every single day. And when you are in that string of bad days, and you relive the trauma. You're reliving everything from your first surgery to then. And it comes crashing down. It comes to a point where I know a lot of these women, I can probably speak for them, where you're just like, oh my gosh, I have to get up again today and convince myself that I can do this. Not that I can just make it through the day, but I can just make it through this next hour, the next 15 minutes. So I know that a lot of these women that are suffering, it's this hole, and then they have to get themselves back out. It is a vicious cycle, and that's one of the reasons why I do what I do, because it's very real, and it's easy to say, well, it's just follow these steps and we'll get there. When you've been struggling for, X amount of years, and it's just, you're still struggling to find answers, and you feel like you are taking the appropriate steps, and then you continue to fall. It's hard. It really is. I completely hear you, and but it's just, there's another side of the story. So these women were ridiculously strong. I know that.
I know, incredibly strong. I think, one of the things that Iris mentioned, which I couldn't agree with more, is the concept of a pain psychologist. Someone that helps people with strategies on not just like to talk about their pain, but actually there's literally things people can do that can make their body hurt less, that are not surgical. I mean, they're literally like magic in the way that your brain works to make your body feel painless. And that's not my expertise. But what I don't like is that sometimes people will talk about sending someone to a pain psychologist as if saying, oh, well, they're just crazy, go see the psychiatrist. It's like, that's not what we're doing. We're actually using a mental health practitioner as a tool to help you not only, and it's not just to make you deal with your pain, it's actually to hurt less. That there are actually psychological tools to helping your nervous system feel less pain. And so you don't need to feel shame at the idea that someone is suggesting that you see a psychologist. It's not shame. It's part of the process of being better.
Right. And I think that comes with embracing it for what it is. And that's hard to do. It took me several years. It took me a long time. So it's a process.
What I notice with my patients when they're talking to me, I like to assess their body language. How are they holding their arms? And I find when my patients are describing their pain, often their arms will cross, they'll sort of hunch over, their legs, one will be crossed over the other, almost like assuming that fetal position that women will, or men, whoever's in pain, particularly with painful periods, they're assuming like a fetal position. And when a woman has tight pelvic floor muscles and they have tight abdominal muscles, tight over the diaphragm, when they're in pain, they go and assume that posture that then just continues to cause and worsen their tight muscles. So the pain psychologist who I work with, she herself has endo, and she allows my patients to feel safe when they are having pain. We're not using a pain psychologist to treat the endometriosis. I want to make that perfectly clear. But that really allows them to then really recognize the things that they are doing that may be then tightening their muscles even further when they're become anxious that they're in pain. So it's an additional tool that has been so beneficial for my patients.
That's fantastic. I actually will be meeting with someone later today to basically talk about this, how to control my pain and how to, just by treating my disease by basically knowing my body, and kind of what Dr. Fogelson was touching base on. So I can keep y'all tuned, up to date on that, because I don't the knife again, y'all. But anyway, yeah. So would anyone else like to add anything else before we head on to the community questions? Are we good?
We're almost up to 100 people watching. It's ticking up.
Hello, everyone. Thank you for all that are tuning in Before we dive into the community questions, I'll ask a favor of you all to share this if you haven't already onto your page, to invite your family and friends to view with us or with you. Okay, so
Hi,
let's
Brittany,
yes.
let me interject here. I'm watching some of these comments here, and they're just really appreciating you. So I wanted to let them know that we see you, and they're very thankful for the panel. I wanted to mention, because Dr. Arrington was late, thanks, Dr. Arrington, for that.
You know what? When I don't control my own schedule, I take what I.
Well, did you want to add on, you kind of missed when Dr. Lee was talking about the importance of a pelvic exam. Did you want to add on to that since you missed that discussion? And just kind of, because of your post on Facebook, you said it's surprising how much you can learn from a adequate pelvic exam. I just wanted to see if you had any feedback on that.
I guess I don't know what I can add because I don't know what was covered. It's just something, I guess recently, for lack of a better way to put it, has become a little bit of a pet peeve for me. When we see patients that have struggled forever, you know, they've had a surgery or not had a surgery, or their doctor died, you know, maybe you have endometriosis, and then they finally find their way to our office and you do an exam based off their symptoms. And the most frequent one is either, you know, pain with intercourse, pain with bowel movements, and you do an appropriate exam, something that we learn to do in medical school that we get docked if we don't do that exam in medical school. And there is an obvious big firm mass in the rectovaginal space, possibly tracking into the rectum, that should be obvious to anyone who does an exam. And it tends to blow my mind a little bit. And part of this is because I think over the years we've become so worried about a malpractice aspect that we rely way too much on imaging, has taken away, I think, the value of a good physical exam and basing clinical judgment off of a good physical exam, even to the point where we were reviewing a vignette for teaching medical students over the summer. And this particular patient had an endometriosis surgery maybe 10 years ago, presents now to the gynecologist with continued pain, and on exam, it goes through the exam and she has a rectovaginal exam, and there's an obvious 5 centimeter firm mass in the rectovaginal space. And there were people giving input on this panel that were essentially discounting what you found on the physical exam, ordering bladder tests for urine infection and all different sorts of things. When you look at the history and you take your physical exam, and you can base a lot off your physical exam, and even to the point where they were arguing against referral to a multidisciplinary center. And again, to me, that ignores something as basic, the most basic thing that we learn in medical school and in residency, is to perform a physical exam and use that first to then justify or direct where you are going to go with the rest of your care and imaging and other things that can add some value into that physical exam. That's all. That's just become one of my latest pet peeves.
I think, like, I'm sure many of you have had the same experience as well. A lot of times I'm seeing patients for pelvic pain and endometriosis, and I'm performing the rectovaginal exam, and they will tell me, like, I'm the first person ever to perform rectovaginal exam on them. And, you know, and then, and when you do that, I say, well, there's obvious nodularity there. How come nobody have ever, you know, examined you that way? And you kind of wonder what it's like out in the community. A lot of people just don't do that type of exam, period.
They never do it. The general OBGYN never does that exam. And many general OBGYNs never do it.
What's surprising is even in large cities, you'll see that in large academic medical centers or very, very high volume programs that offer all the stuff, transplants, you know, major orthopedic reconstructive surgery. Something as simple as doing a proper, you know, targeted exam is oftentimes not done. I have colleagues who actually will brag that they will take a patient to the operating room without even doing a pelvic exam because they've done so much endometriosis surgery. And I think it's a little bit misguided. It suggests somehow that that endometriosis responds to one pathway for treatment, and I don't think it really teaches the patient anything about the sort of course of the disease either.
No. Okay. Well, let's go ahead and dive into the questions if everyone's ready. And hi, everyone. I'm so excited that y'all are here. We have some great questions. I'm so glad that Joy interjected and said hello and said that you guys are enjoying the show. Right now, these questions did come in from the community. We will touch base on these. If you have a question, you're watching live, go ahead and post it in the comments below. Joy's keeping an eye out for that, as well as our time. So if we get to a point where we can get to your question, we definitely will. So let's start with Fonda's question. She is 57 years old. She has a total hysterectomy in 2002 for stage 4 endometriosis. I have inner thigh left leg pain that radiates to my ankle that is constant for many years. I since had 2 excision endosurgeries with stage 4. I can't find a way to help treat this nerve pain. What type of doctor and treatments are available to me? I live in San Diego, but can travel or relocate. I have been on gabapentin for years. I tried Pudendal nerve blocks too. I tried S1 nerve blocks. It has not helped. When I lay on my right side in bed, my left leg pain is worse. Crazy. Sitting also makes it worse. Any tips to help me find relief? And I'm going to throw this over to Dr. Tu first.
Yeah, right. This is a very complicated presentation. It involves an individual who's obviously suffered quite a bit and has had a persistent sequela of symptoms. Now even going from when she was 41 until now, she's presumably postmenopausal, both from the surgery and from just age. A couple things come to mind. First of all, the use of something like a gabapentin type drug suggests that the previous doctors or clinicians have thought this is some sort of a centralized pain phenomenon, and it might be. The use of a sacral nerve block, whether it's at the S1 nerve root or whether it's looking at the peripheral branches of the pudendal nerve, is really only something you can comment on if you actually can see the clinical exam. What strikes me is that the patient, Fonda, is able to say that she feels this pain on the inside of her thigh. And so let's just run with that and not worry about anything else that's been treated on her. If this pain developed after the surgery, it might not have anything to do with endometriosis, but might have something to do with simply either her postural changes after surgery or something that happened during the surgery, like a possible compression. And it could involve something like the oculator nerve, which actually would provide some of the innervations in this area. In the area you live in Southern California, there's no question that you could probably see someone either in physiatry, a physical medicine doctor, or a very, very qualified physical therapist. Dr. Orbach, I'm sure, has a whole list of names in that area. But the key would be to replicate the pain and look at the overall sensory exam. Is there normal sensation in the leg in general? Is there any issues with the hip or the pelvic floor? This is actually a great example about some of the things we talked about earlier in terms of trying to get down to what does the exam and the history tell us here. And there's still a few things they're missing here that would make me think that she might have a great opportunity to respond to very calculated and very directed physical therapy or to a selective nerve blocks.
I would add to this, one of the areas I've been studying neuropelviology, which is the sort of pelvic neurosurgery, is developed by a Swiss gentleman, or French-Swiss gentleman named Dr. Passover, and I've been doing that work. In a case like this, I would want to know a lot about the endometriosis, because if they said that there was a big endometrioma on the left that was invasive into like the pelvic brim area, that would kind of ring a bell in my mind, because her symptoms sound like a S1 or S2 nerve root on the left side. Although rare, it is possible to actually have endometriosis that is literally on that nerve root. And there are very few surgeons that really know how to get there. And I'm not saying that that's what she has or not. You would really have to thoroughly evaluate this patient. But with a really detailed neurologic exam, one would be able to determine exactly what nerve roots are being irritated in her and come up with a construct on why that is. And it's not impossible that there is something that could be addressed surgically that might make it better. But I completely agree with Dr. Tu that I wouldn't jump into that without trying all kinds of non-surgical things, and I wouldn't jump into it at all unless the neurologic exam very clearly told us S2 nerve root is being irritated. And then we try to do, or S1 or whatever, and then you do a block and it gets better. She said she had this S1 block and it didn't get better. That would suggest that at least that root's not the problem. But But if you were to block a root and it did get better and then it got worse again, and you have the right history, selective neurolysis of certain nerves in the pelvis might be of benefit. But every case is so individual that I'm afraid to imply to this particular patient that that's what she needs, because you really would have to thoroughly evaluate such a patient to really make any determination.
Just a couple thoughts about that. The question is, what dose of gabapentin is she on? Most patients who come into my office, they're on subtherapeutic doses, like perhaps she's on 300 milligrams, and that's subtherapeutic for her of GABA, and she may need a lot more gabapentin. So typically I find that. Secondly, who did the pudendal nerve block? If it was an OBGYN versus someone who's a physical medicine rehab or anesthesia or pain, was it done under ultrasound guidance? Did they really get the pudendal nerve? Was it done under imaging? So I think that's very important. What did they use for the block? Was it just something short acting like lidocaine, and the patient actually got better for short-term duration? So she did have benefit, but she's thinking it didn't help because it didn't provide long-term benefit. I think lots of times when you're adding Trameal and a lot of different things in the injections, the patients do a lot better. And if this patient's down in San Diego, there's some great comprehensive PT down in San Diego is fantastic. I would start with pelvic floor physical therapy. It's the easiest thing to do, and you never know. Before I would jump, as much I love to operate, but before I would ever jump to operate, I would say PT, make sure your dosage of GABA is appropriate, and make sure you're being evaluated by someone in a comprehensive way.
I think the other possibility for this patient could be the genitofemoral nerve that innervate the inner thigh and labia area. So that's a possibility. And obviously, if you have endometriosis involving the left ovary, for example, I mean, that area is very, very close. And then at the time of the surgery, that there may be some, especially if her hysterectomy was done open, the genitofemoral nerve with a retractor can actually put a lot of stretch on the genitofemoral nerve, and that could be a nerve injury as well. So there are different possibilities that without examining the patient, it's there's obviously a lot of speculation here.
Sure. Okay, Dr. Arrington, this one is for you from Kim. How do we get the medical community to learn more and pay more attention to this disease? It's time, she says.
Again, I guess if we had the answer to that, it probably would have happened 25 years ago. I know for red wine and some of those who've been around it for years and years, it's been a very, very long battle. I think right now, really for the last 3-4 years that I've really been more involved in the endo community, I really think it's going to come down to patients. We have tried, medical colleagues talking to each other for 25-30 years, have made very limited progress. At this point, the only thing that we have really seen, well, I wouldn't say the only thing, but the most significant thing we've seen that is new is there is a much greater patient voice. I really do think that change with this is going to be patient driven. In sharing information, sharing success stories, and even sharing failures with those of us who do a lot of excision. There is benefit to us in understanding, like Nick said earlier, those patients who didn't meet their operative goals or their pain goals on not only did they not meet them, but have they found things outside of what we are able to offer that they have found to be beneficial, so that we can then advocate and offer more things for our patients. Boy, it's tough. I really do think it's going to be more patient driven. Certainly on a physician point, we talk, but the doctors who deal with this on a routine basis in the communities really have to have an interest in even spending time on that. And truthfully, I'll bet you a number of them have not even addressed endometriosis or done any significant journal searching, article searching since they left residency. And if there's no interest in them, no desire to look, it's hard to reach them from a collegial or from a professional aspect. And for me, that's going to have to come from patients.
I just wanted to mention something that was just happened recently to me that was really quite inspirational to me, is that I was fortunate to be invited to give grand rounds at Baylor a couple of weeks ago, and I gave a lecture to medical residents and medical students, and a few local physicians as well, about endometriosis surgery. And I showed a lot of videos, and then I dissected a cadaver with the residents and did all the anatomy, all the retroperitoneal anatomy and everything. And I had 3 different residents come up to me and say, how can I become an endometriosis surgeon? Like, what I had shown them was, somewhat inspirational to them, I guess. And they said, wow, this is something I want to do. And it goes to show you that, just a few hours of education to people at the right point in their career can be something that really inspires them to take that path in their life. Whereas if someone's been out there for 15 years and they don't really believe in endometriosis excision, you can beat them over the head with it forever, and they'll still tell you you're a charlatan, And so, maybe it's wasted time trying to convince the 50-year-old doc about endometriosis surgery. You convince the 28-year-old resident, and it's probably more effective.
Yeah, there's definitely a serious lack of education at the residence level. The majority of OB/GYN residency programs in this country do not have anybody within their program to teach them about endometriosis as well as endometriosis surgery. So I would say 90%, 95% of OB/GYN residents graduate without exposure, but they have never seen a good excision endometriosis ever throughout their 4-year residencies. And so the lack of exposure is sort of the root of the problem. And what we're trying to do with the fellowship with AAGO is to populate the countries with all the people who've been trained and populate them throughout different training program. And that's really the way to change the course. And education is the only way to do that. And so you have to do it at the residence level, as Nick had mentioned previously.
And Ted, it's slow growing, but I completely agree with that. When I was back in fellowship, I think there were 13 sites throughout the nation. I have no idea how many there are now. Most of the fellows that are turning out at least have been exposed to advanced endometriosis surgery. And anecdotally, I found in the community, leaving a smaller community in Utah, that there are more and more regular gynecologists who, when they encounter endometriosis, more and more are excising what they recognize and what they feel comfortable doing. And then there's a whole, stratified group that some will then refer on. If they find stuff that they can't treat, they'll refer on to a specialist. Other ones will just say, hey, I got what I can. We need to try something else. But they're slowly in the community, we are seeing more regular OBGYNs excising what they find, as long as they feel comfortable doing those areas, as opposed to just quick burn or laser.
Right.
I think what would be so fantastic to help teach the OBGYNs is we all have to do maintenance of certification questions. Why can't we have a really good article about excision of endometriosis improving outcomes as compared to ablation to educate the general OBGYNs? I wish that ABOG would choose a really good endo article, or just an article talking about that many of the symptoms of endometriosis are intestinal. They're constipation or bloating or painful dyschezia, painful bowel movements. I think most OBGYNs don't even recognize the symptoms of endometriosis. They still think today that endometriosis only is if you have pain confined to your period. So if someone has pull with ABOG, to the American Board of OBGYN, to make one of those articles talking about the symptoms and how do we diagnose it and how excision is better than ablation, I really think that would be very impactful for OBGYNs. I try and give rounds to the Department of GI. I'm giving rounds to the grand rounds to pediatricians in December. I try and give grand rounds to all of these other people who will pick up these patients, because most people don't think that a teen can have endo. Or most GIs think that if someone has bloating or diarrhea or constipation, they're IBS. Why don't you ask them 2 questions? Do you have painful sex and painful periods? You can triage them in 8 seconds and send them to a gynecologist. So I think we have to rethink how we are educating, and we're doing it one person at a time, but it's just way too slow.
Yes.
That's my 2 cents.
Very
Everybody, I'm going to have to go in about 5 minutes. So when I say bye, I'm going to say bye, and I appreciate all the time. My flight is going to board in about 15.
okay. Do you want me to skip down to one of your questions? Do you think 5 minutes is enough?
Sure.
Okay. So this is for you, Dr. Fogelson. Katie asked, previously diagnosed with endo, fibroids, blocked fallopian tube, a lab and a myomectomy
Mm-hmm.
were done prior to fertility treatments. After my IVF twins were born, I was in pain again and with more intensity. Pelvic ultrasound done and adeno was noted. I had a total hysterectomy in September 2017 for adenomyosis. I still have pain and it's gotten worse. Tried Lupron for the second time, but the side effects were debilitating. My gynecologist wants me to take my ovaries, but no endo was seen on them during hysterectomy. I think it's somewhere else. What do I do? I'm tired of being in so much pain. I'm reluctant to get rid of my ovaries because I think I'll still be in pain. Looking for advice.
Well, I remember seeing this question, and I gotta have to reiterate that I can't give very specific medical advice on what this particular person should do. The question ultimately, so the uterus is no longer a source of pain because the uterus has been removed. The question is are there pelvic floor issues that are involved? Do we need to involve a pelvic floor physiotherapist? She mentions Lupron was causing a lot of side effects. I would have the question, did she see any benefit in pain from Lupron? Although I don't use Lupron really hardly ever. In fact, I haven't for many, many years. If someone came to me on Lupron, I'm still interested. Did they have any improvement in their pain on Lupron? Because if they did, then it may be related to endometriosis. Because even though Lupron is not a good treatment for endometriosis for a host of reasons, it does reduce endometriosis symptoms in a lot of people. So the question is, was she better, but she had side effects, so she went off of it? If so, there may be, after looking at pelvic floor therapy, after looking at maybe she needs, Botox potentially, I would do a very thorough neurologic exam and see if there's any evidence of any sort of lower extremity or pelvic nerve dysfunction. And then one has to really evaluate previous operative notes and say, okay, was there evidence of endometriosis that was not removed? Because if she had a laparoscopic surgery that was not really identified endometriosis that wasn't removed, then there may be benefit in doing that. And certainly, even though one has had a hysterectomy, one can go back laparoscopically and resect endometriosis that may be present. The other thing is that if someone was in that situation and they really didn't want to have surgery and they had seen some benefit from some sort of other medical therapy, a really simple medical therapy that doesn't have a lot of downsides is progesterone. Taking 5 or 10 milligrams of norethindrone acetate is not going to lead to long-term obliteration of endometriosis, but many people that have some residual endometriotic pain have improvement when they're on 5 or 10 milligrams of norethindrone acetate. And if they can just take that once a day and feel better, then great. I don't have the sense that just because there's endometriosis left behind that you have to operate. I mean, medical therapy is effective for some people. So, without giving this person very specific advice, that would be on the palette of things that I would consider for sure. I would also consider acupuncture. I would look at their diet. I have sent people to health coaches at times to help them to implement dietary changes. I can give someone a diet. I can tell them to eat an anti-inflammatory diet, but if they don't have a very specific, someone really helping them to adhere to some sort of life change like that, and they're not likely to succeed at it. So sometimes we refer to people who are not particularly expensive to be involved with that will check up with them every week or every 2 weeks and help them to make diet plans and help them to talk about exercise and doing other things that are going to have ancillary benefit for them. And that's what I would add. But otherwise, I would have to see such a person and really evaluate them specifically to come up with a more specific idea.
Sure. Anyone else want to add?
I think specifically, related to endometriosis, as Nick said, that operative reports, pictures, just to get an idea of what was encountered at the surgery can go a long way to let us know, what is the potential risk of there still being an endometriosis component to what she's feeling.
Mm-hmm.
And I think it's important that not all gynecologists recognize endometriosis. I had a young woman who came who had a hysterectomy, and then she said, I'm still in pain. She couldn't get me the operative report. I examined her. She had a mass about 5 centimeters eroding into her rectum of endometriosis. And that was not picked up by her gynecologist as endometriosis. So I think it's important to know that not all gynecologists really know what endometriosis looks like. So, you know, like what we talked about, listening to the patient and a good thorough physical exam is so important to figure out what's really causing their pain.
Yeah, that's why we mentioned that op reports are frequently unreliable in many situations, unless you know the surgeons, you know, well. For example, if you know, ours have done the surgery and I review the op report, and you know, and I'll trust that and say, okay, that it was done by previously a good surgeon, and then so the operative findings are accurate. But a lot of times when we get op report, let's say no endometriosis, and there's a lot of endometriosis, and vice versa. And there are op reports to the patient that lots of endometriosis, and when you go in there, there's no endometriosis.
So I'm going to have to go. Joy and Brittany, thank you so much. And Frank and Iris and Jeff and Ted, thanks so much for your collegiality throughout my career. And I look forward to seeing you at AAGL in November.
We appreciate your time.
Safe travel.
Bye-bye.
Bye.
You know, certain keys in an operative report that I look for. So many doctors get in and they may not recognize endo, but they'll talk about an ovary being stuck to the side of the pelvis or the ovaries being stuck to the back of the uterus. They describe adhesions, and then they talk about time spent in great detail separating adhesions or lysing adhesions. They take the time to try to free everything up, but yet they don't step back and think what caused those adhesions in the first place. To me, that can be an operative report trigger even if they don't find any endometriosis. If they're dealing with massive adhesions or significant adhesions, free those up, but then they don't address the disease that caused it. That can be just one small little trigger in an otherwise suboptimal operative report that would raise the suspicion for me.
Totally agree.
Okay, so let's move on to our next question. This one is for Dr. Orbach. Erica asks, I have a question regarding reoccurring pain after a full hysterectomy. Only kept my ovaries. I have 2 children and had surgery at age 28. I am now 30 and am experiencing pelvic vaginal pain. Doctor said, and I quote, after we remove the uterus, the rest of the endo will just shrivel up and die, aka no excision. What are my options now?
Wow. It's unfortunate, but we see this way too often, and it's just really heartbreaking. So I think we've got to take a good history. We've got to listen what's causing the pelvic and vaginal pain. Have it before you had the hysterectomy? Did it start post-hysterectomy? What aggravates it? And then it's a good physical exam, examining the vaginal cuff. Am I feeling scarring? Am I feeling endometriosis? Is the bowel stuck to it? But probably one of the first places I would send the patient is probably pelvic floor physical therapy, because perhaps the muscles are very tight from the years of pain. But this is the kind of patient that you need to see in the office and do a proper exam on. It's really hard to guide someone what to do without a good physical exam.
Sure.
But I would imagine that there's some muscle tightness. There's probably endometriosis that was not excised. Yeah.
Okay. Anyone else want to add to this particular question? No?
Yeah, this is a very common theme here. I think a lot of the questions that was asked were patients who already have hysterectomies and are still having pain. And, you know, I mean, certainly endometriosis is can be one of the differential diagnoses. And the physical exam definitely is key. Obviously, in patients who have very focal tenderness and longularities on exam after hysterectomy, those patients are a very good surgical candidate in the right hand. And so it's, but on the other hand, there are patients who may just have, levator tenderness, evidence of centralized pain. Those patients just need to be triaged appropriately to the right providers. So I think as an endometriosis surgeon, you need to be very, very good on other different differential diagnosis of pelvic pain. You cannot just, and sometimes I feel that it's like a device. There are some endometriosis surgeons who are very good surgically, but they may not be very good in terms of, have the familiarity with the other diagnosis. So I think that's, there needs to be much more, I think if you want to be a good endometriosis surgeon, you need to know other aspects of pelvic pain.
I think in this particular patient too, though, there is 100% chance that she still has endometriosis. And that is going to be hard for her to get over as well. And without knowing how bad it was or what they found, regardless of whether it's a stage 1 or it's stage 4, invasive, like Iris mentioned with the 5 centimeter invasive rectal stuff, she has 100% chance of having endometriosis because she was told that it would die off, and it doesn't.
And
my only sort of comment on that is that I've seen enough seemingly well-trained surgeons tell my patients in exquisite detail about endometriosis, gone in and reoperated and found absolutely none. That, Jeff, I want to say that in the situations we've experienced, I'm quite reassured that there will be some people who will not have endo when you go back in here in this situation. So I wouldn't hold out all hope, but it is concerning though that the patient had what it was apparently a disease that was left untreated. But again, to reiterate my comments, I think it's important not to leave patients with this almost continuous pessimistic view that this is some horrific, unrelenting disease that is attempting to wipe out womankind. It does not promote general cognitive wellness to have that mentality. It doesn't mean that this woman doesn't need another look, but we've had enough cases in the last several months where very, very confident surgeons who I would have thought for sure would have nailed the diagnosis. I don't know what they saw when they went in there, but it was not endometriosis. And they even had black and white pictures that I got, and I was like, this doesn't really look like much, but the guy swears up and down, or the woman, in his opera was like, there was extensive endo. So there's still a big gulf in what people think they believe about endo and what they actually are unfortunately running into. That, this is why you need histology. You need a path report, not just an op report, if at all possible.
And agree with that too. And again, the fact that she, assuming that she does have endo, again, the question comes to, is that the pain generator or the bulk of the pain generators that she's having? I mean, we all see patients all the time where their doctor describes disseminated endometriosis over the omentum and the sides of the abdomen and everywhere. And you look at them and we know that it's not endo, it's a ruptured endometrioma with hemosiderin staining, where it just goes, I guess, recognizing endometriosis, what is and what is not, it goes both ways. Agreed, Frank.
And if I want to, I'd love to add, because I think often a patient will come in and they'll tell you what they think are the important symptoms, but there's actually so many other important symptoms that they're not recognizing. So for instance, for this patient, I would want to know, does she have painful bowel movements? Does she have constipation? And did the constipation start after the hysterectomy, before? And if she says, oh, I've been constipated since I was 13 or when I was 15, and then she says that she's straining on the toilet and now she's, how old is she? 28. So then she's had these tight muscles for 13 years. And that could be causing a lot of the symptoms. I think it's important to ask urological symptoms as well, because maybe she has a component of painful bladder syndrome or interstitial cystitis, whatever you want to refer it to, which it can be Endo's evil twin. So perhaps that's a non-surgical treatment. So I think we have to ask the right questions. It's really hard in 3-4 sentences to make the diagnosis without the physical exam and without having the time to talk to someone. But I think she should see someone who specializes in pelvic pain to really tease it out and help her get better.
Okay, so let's go over to, let's see, Dr. 2. This one is for you from Heather. My daughter has classic Turner syndrome and miraculously, spontaneously started her period a few months ago. This is extremely rare in girls with TS. Endometriosis runs deep among the girls and women in my family. Have you ever known of a patient who has had both Turner syndrome and endometriosis?
I really appreciate, Brittany, that Joy sent us some of the questions ahead of time. This one's a little bit of an unusual kind of admixture of situations. Number one, it's a little bit unusual for a woman with Turner syndrome to have, so this is this is a chromosomal issue where you're actually missing an X chromosome, or at least on the face you may be. But the traditional patient who doesn't have both X chromosomes can actually present as a mosaic, where they do actually have a copy. It's not consistent across their genetic code. So it's possible that this woman, if she spontaneously started a period despite being diagnosed with Turner's, is actually a mosaic and actually does have an X chromosome just in one of her complements, and that would be much more likely. In that case, then the simple question is, if you're going to have periods, are you at risk for endometriosis? And the answer is, of course. Fortunately, we still know that endometriosis in general is only affecting about 5% of the population in general. And if this young girl hopefully never has any issues with pain, then if she's fortunate, she'll never have to find out if she has endometriosis. And I think that that's the attitude we take with most people, is we don't try to stoke fears about risk unless there's symptoms to begin with or there's unusual signs on the exam. Let's keep our fingers crossed for this young woman, certainly.
Absolutely. Okay, Dr. Arrington, Rose asks this: 6 years old with a 5 centimeter on the diaphragm. I'm guessing it doesn't say a cyst, 5 centimeter cyst maybe? I'm not sure. 5 centimeters with a 5 centimeter on the diagram, abdominal, bowels, and other bowel issues. Looking for help living on pain meds. Can insomnia be caused by endometriosis?
So possible endometriosis on the diaphragm, the bowel, elsewhere in the pelvis.
Mm-hmm.
But the main question is regarding insomnia, correct?
Correct. Can that be caused by endo?
I guess it depends on what the cause of the insomnia is. Certainly, if a patient is painful, we've all had patients who their pain is significant enough that it wakes them up in the night.
Mm-hmm.
I don't know if that would be is technically classified as insomnia, as not being able to fall asleep. Trying to think, I'm trying to think various pain meds. Normal narcotic type stuff wouldn't affect that. Some of the others may have ideas. The gabapentin's usually a more of a sedative effect, if I'm not mistaken as well. I'm just trying to think of what other pain, what other ancillary medicines that could play into the insomnia. The only thing I could think of is how much is this is the pain affecting the patient, and is that enough? Is it to the point where it's keeping her awake, or not necessarily in the insomnia, but just not being able to get a good, restful, full night's sleep?
Right. Okay. I'm going to hop over to Dr. Lee. I have a question for Barb. I had a complete hysterectomy a few years ago at the age of 41, 42, but still have extreme pain. After having 3 children with endo, and it got 10 times worse. I'm on a hormone patch. In our community, our doctors are not very educated in endo. Any thoughts or suggestions on my next step?
Yeah, I think this case obviously is just another one of those patients who have pain after hysterectomy, and in her case, she apparently had both ovaries removed as well, and she's on hormonal patch. So I actually see a lot of these patients in my practice. I see a lot of patients who has pain after hysterectomy. If she had endometriosis in the past, there is a good chance that, one of the things I kind of ask in the patients is that when I see this type of patients that, they could have a condition called ovarian remnant. A lot of times, especially when we have severe endometriosis, pieces of ovary can be left behind. And so a lot of times what I would do is tell them to hold off their hormonal patch for about 2 weeks and check their hormonal profile. And if their hormonal profile shows their hormonal profile is in a premenopausal range,
Mm-hmm.
it's pretty much 100% this patient still has a small piece of ovary left behind.
Okay.
Also, in those type of patients, they also have endometriosis left behind as well. So in this type of patient, if I prove that they have ovarian remnant with a hormonal profile that's in the menopausal range, I'll remove the ovarian remnant. I also remove endometriosis as well in this type of patients. And those are the the type of patient I like, because this is something that I can fix with surgery. Certainly, there are people who would treat ovarian remnant with Rupron, but frequently in the long term, they frequently are not very effective. And with ovarian remnant, the surgery are risky, because there are frequently a lot of pretty high risk for having bowel involvement. The risk for enterotomy, making a hole in the rectum, it's relatively high. The ureters are pretty much all scarring to the remnant. So the remnant is actually on the ureter at times for this patients. So this would be the, if it's something surgical that we can treat, this would be the type of patient. Certainly, the other type of source of pain, like centralized pelvic pain, and other causes of pain, obviously will require a careful physical exam.
Okay. All right, Dr. Orbach, this one is coming to you. This is from Shannon. Okay, so severe unrelenting fatigue with endo, can hardly function. So her question is, can this unrelenting fatigue come along with endo?
Absolutely. Endometriosis is inflammatory in origin, and I'd say most of the patients who come in, fatigue, if you question them, is one of their biggest, one of the big symptoms that they describe. And what I see a lot in my patients is the difference prior to excision and post-excision, how much less fatigue the patients have once you excise the endo, which is inflammatory. And I think it's the years of this inflammatory environment, which is setting off all these cytokines and interleukins and all these other inflammatory processes. Plus, the patients just don't feel well. So if they used to work out, they're probably not working out as much. If they used to go out and socialize, they're probably not feeling so well, so they're not going out. And yeah, I definitely think that fatigue is a huge component of endometriosis, and there's definite improvement post-excision.
Okay. Anyone else want to add to that?
This sort of dovetails with the insomnia question that Dr. Ingram was talking about, and I think that Iris's comments kind of about the sort of biochemical pathways that might explain it probably are similar for the two. But it's also important to note that we have a lot of patients that are looking to try to find a single answer for a lot of symptoms, and the reality is, if you take a patient who has chronic migraines or chronic low back pain or has lupus or has hypothyroidism, oftentimes there'll be a common set of presentations where fatigue is unfortunately almost always going to be part of that, because like Iris said, once you sort of have persistent inflammation and activation or dysregulation of the autonomic nervous system, all of these things sort of start to happen in chronic disease. And so it is oftentimes easy to try to say that, X label explains why you have fatigue, but the reality is that these are common outcomes for the ill individual. And so I think she alluded to this a little bit, you encourage people to try to fight through that, get some exercise in, get proper sleep, make sure they're, having a balanced diet. You don't have to have an endo patient to treat fatigue. You can treat fatigue in almost any of the patients that present with fatigue the same way. You've got to keep them moving and give them the positive support, make sure that, stress, diet, environment are all optimized. It's a very common complaint, unfortunately. It's one of the most difficult parts of any of these diseases, not just endo.
And one other to add, sometimes women have to urinate 2, 3, 4 times a night because perhaps concomitant painful bladder syndrome, or they have such pelvic floor dysfunction that they have to, the urge to urinate, so they're not ever getting into REM sleep. So then they're so exhausted. So then there's that compounding effect in addition to the inflammatory effect of the endometriosis. So again, it's a really thorough history and a really good physical to try and figure out the answer.
Okay. Let's see, Dr. Lee. This one is for you from Heather. I was diagnosed 2006, had it on okay, you're gonna have to help me with this one, urosacral, is that right? Ligament.
Which question is that one?
This is from Cheryl.
Okay.
Now, her gynecologist, it says that it was layered and she had scarring on her ovary. This is what her gynecologist told her. Last 5 years, she has had major bloating to the point it happens every day, and constipation. I have done all the tests with the GI. They say I have IBS constipation. I had a total hysterectomy this past June. Gynecologist said he didn't see any endo, but pathology came back, brown-filled cyst and pigmented macrophages. Gynecologist said hysterectomy will cure my endo. I don't have as much pain as I had with adenomyosis. question is, should I see a specialist because of my bloating and constipation? I believe it must be on my bowels. I'm assuming she means the endo on her bowels.
Yeah, I think there's definitely a possibility that her endometriosis could be on her bowel, given that, you know, her ovary is scarred to her uterosacral ligaments. And so that's a very common site for severe endometriosis. It's definitely a possibility. And the fact that her gynecologist said that she does not have endometriosis, you know, it's one of those things that you cannot completely trust. The pathology come back, brown field cysts and pigmented macrophages. There's a good chance that if a good pathologist may say that's endometriosis related. So yeah, definitely with the good physical exams, I think, you know, if they point out that she has focal tenderness on the sacral ligaments, you know, next to the rectum, certainly that's a potential direction that we can go with that. But on the other hand, you know, certainly patient may have IBS as well, but that's why a careful exam will give us a lot of information.
And it may be that she doesn't have rectal involvement. I think in patients who present with painful bowel movements, constipation bowel symptoms, probably more of those have deep disease or disease in the uterosacral ligament triggering the hypogastric nerves that run to the rectum as opposed to direct rectal involvement itself. I think the nerve involvement or perinerve involvement is probably more common than the direct rectal involvement, at least from what I have seen.
Right, I definitely agree with that. Actually, the majority of the patients who have dyschezia or painful bowel movement do not have endometriosis of the bowel, just simply because the way the pelvis is like a funnel. It gets narrow towards the bottom, and so frequently, if you have endometriosis on the uterosacral ligaments, the friction of that area as the bowel movement passes through, you're gonna have pain with bowel movement, and not necessarily have direct invasive disease to the bowel. So that's totally, you know, so common things are common. So the majority of patients with dyschezia or painful bowel movement do not have invasive disease to the bowel. But of course, the exams will give us a lot of information on that as well.
Exactly. Okay, so guys, we have about 5 minutes left if you're wanting to wrap up at 6 o'clock. So I wanted to kind of throw a curveball. I just had a message come in on one of the live videos that I shared in a support group. And I kind of wanted to get, it's actually kind of a comment. I wanted to get your thoughts on it because I didn't want to leave this person with this the only impression. She said, I think the biggest takeaway I had from this is, and what I think many of us have learned the hard way, is that OBGYNs are not always well-versed or knowledgeable in endo, and it's best to make sure you are seeing a specialist. Would y'all like to shed some light on that? Because I know that is a very sensitive subject in the endo community because not everyone can afford to go to a specialist or have one that's nearby. So they're utilizing what they can and what they have around them. So what would you leave everyone with if that's what they're from this?
Yeah, I'm happy to start, but I think there'll be a lot of opinions about this. You have to keep it simple, right? We could talk about a very complicated solution that's not going to work,
Sure.
but the reality is that not everyone can travel and not everyone wants to travel. The first thing is just to make sure that patients are even aware. If we start with younger patients who have painful periods, and I mean like 13 to 15-year-olds, and make sure that we do an adequately good job of reducing pain from periods, it's probable that some cases that involve getting endometriosis-associated pain will never reach a level that is clinically meaningful if we can make sure that they don't get early exposure to painful periods that's untreated for years. This is the kids missing school, missing athletic events, missing social engagement. You deal with that first, wherever you live. You're going to knock a ton of cases of symptomatic endometriosis out right off the bat, and we don't do a great job of that. My colleague Kevin Hellman's done some very nice work showing that something as simple as taking a leave consistently around the time of the period is probably not done by 2/3 of individuals, and so we can do a better job of promoting that message. That's one. The second thing is that I think that you've heard enough that there is a role for pelvic floor physical therapy or for doing physical therapy in general. So because the other people will talk about what can we do about trying to get better surgical treatments into the community, and that, I don't think I have the intelligence to know how to solve that policy problem. But physical therapy, we can probably do a better job of teaching. There's a lot of therapists who are willing to go and get training, come back to their community, and there are therapists, fortunately, in most of the major communities that we're talking about here. We start with that, get people moving, get them feeling optimistic. That'll get us a lot of the way. But I'm sure the other people will need to advise about how can we get better surgical training, and that's a huge part of it. Absolutely.
Very well said.
I think we're doing our best trying to, educate as many people through the fellowship program and through all the postgraduate courses that we do. I think the better we do in terms of educating our residents, the residents who are in training, the better it will be for the patients. And that's really the key to this, is if we don't train the residents and the residents never get exposure, they're not going to get better. So that's very, very important to do that.
Brittany, just one other thing to add into that, if I can, sometimes my thoughts start to leave me a little bit. But ACOG right now is undergoing a renovation of their endometriosis quote care protocol or practice bulletin. And really, I think if we can use whatever form we can, and hopefully ACOG will correct the errors that they've had in the past, and really allow doctors to understand what the roles of all of these treatments are in endometriosis. What is the role of ibuprofen? What is the role of any number of hormone therapies? What is the role of Lupron or GnRH agonists, all those sorts of things, and understanding that those are palliative, classify them as palliative interventions, but also be willing to discuss surgical intervention and what the goals and outcomes of each of those are. And if we can teach those doctors on a community basis what the true value and what the true goal of every one of those treatments along that spectrum is, and then allow them the opportunity to look at this and say, hey, if this really ends up being more like a cancer case, most regular GYNs, if they get in and unexpectedly find a cancer or they suspect a cancer, they're not going to do the surgery. They're going to document, they're going to refer on, and allow them the ability to refer those most difficult cases. And as Frank mentioned, in the younger patients, if we can at least raise that red flag and say, painful periods to where you are missing school, to where you are missing the things that you like to do, you have a very, very, very high chance of having endometriosis. And they need to be aware of that, because even though we can control the pain, we don't have a good understanding of what endometriosis will be superficial and relatively benign, and what endometriosis will be destructive. And that patient needs to be aware of that as she gets older, even into late teens, early 20s, that she needs to have a physician who will do a good physical exam and try to be able to pick up some of those patients with the more destructive forms of endometriosis as they grow.
I love the idea of educating the teens and having the school nurses picking up the patients. But the problem is there's a lot of docs who think that ablating the endo in these teens and bringing them back on a yearly or every 2-year basis for their annual ablation surgery is the right way to go. But you're not treating the disease properly, then you're upregulating the central nervous system. And I've had so many of these younger patients who just haven't been treated properly. So I think we've got to somehow spread awareness as well as proper education. And I think it would be great if it was like in Europe, where they channel the patients to endo specialists.
Oh, wow.
Like they do in France. And I think the insurance companies have to not allow docs who are doing under a certain number of cases a year to operate on patients. I don't do any urological surgeries, even though a bunch of my fellowship was doing suspensions, but I shouldn't be doing them because I don't do enough. I don't do any because there's other people who can do it better than me. I think we should all really refer to the right docs.
Absolutely. Thank you guys for adding that. And I agree 100%. We need more awareness. And that just means that us as patients and advocates, we're not done. We need to continue spreading the word. We need to continue sharing our stories. Our voices matter. Educate yourself and your family members. Go into your appointments equipped. Take this knowledge that you're learning and do any research that you can on your end as well. So whenever you go in and you speak with a doctor, whether it be a specialist or not, you are knowledgeable. You know what they're telling you is either something you need to investigate more, or you can trust them. It boils down to we are our own best advocates. So thank you, doctors, so much for your time. I appreciate each and every one of you. And is there anything that y'all would like to add before we wrap this up?
Can I add one thing for patients to come into their appointments prepared? If they can send the records in advance so we can read them prior to the appointment, and if they can even write on a one-page document just a timeline of what's been going on and the tests that they've had done, it is so helpful, because very often the patients will come in, they'll spend half of our discussion looking on their phones to try and find the operative report, the pathology report, and it could just be so much more productive if they can get all those records in advance. And if it means having to go to those doctors' offices or the hospitals to chase them down, it's so much more beneficial for the patients. Or if they were on a medicine, what dosage were they on, for how long? Just to come in really, it's usually been a long journey and it's hard to remember all those things, but it certainly would help us give them answers.
Sure. Absolutely. Okay,
Two
everyone.
quick resources to throw out. Number one, along those lines about records, International Pelvic Pain Society, which Iris alluded to earlier, does have a website, pelvicpain.org. There's a standardized history and physical that patients could fill out for themselves if their doctor maybe isn't quite sure about what questions to ask. There's also a series of videos on the patient-facing side that actually go through a lot of these concepts, very brief, 2 to 5 minutes each, that were produced by the society to try to do better education about some of the harder concepts like central sensitization that frankly confuse all of us sometimes. And the second part to that I think is really important for what Iris and others have said is, if you can get better documentation at the time of surgery, one courtesy that I do for myself and for my patient is when I'm done with the OR, I actually take the pictures when I'm giving them to the patient and actually have the patients take their iPhones out and have them literally let me record a brief video of me walking through the pictures as I'm describing to the family. It takes about a minute. And that way, 20 years from now, if someone is trying to explain what happened, they don't have to. They can just pull it off their computer. I had this courtesy given to me for something unrelated, and I realized that we have this amazing tool. Even if we can't videotape our surgeries, which many hospitals don't allow, we can give you the actual real-time description of what we thought we saw at that date and time. And a lot of my patients' families are just so grateful they don't have to explain what I was talking about. I talk too fast, I've got too many jargon terms, but the patient can sit there and listen to it 4 or 5 times, and I've gotten a lot of very positive feedback that it just makes the whole thing less stressful for them.
That is an awesome tool, Frank.
Yeah, I love that.
We all have one. I've got mine right here.
Yeah.
Okay, everyone. So you can tune in to Endometriosis Live to get in touch with any of these experts. Their information will be listed at Endometriosis Live. Also, stay tuned to Endometriosis Live for the upcoming International Endometriosis Expert Q&A. And until then, we will see you then. Have a great day, everyone. Thanks for joining us.
Bye.
Bye-bye.